Thank you, Kim.
All right, folks, we are 2 minutes past the hour. We may or may not have people filter in as we continue to just jump in. But with that, I'm going to propose that we dive right in. So welcome, folks, and thank you all for being here. Today is the second and final dental provider work group meeting. I really appreciate everyone for making their time the time today, and let's jump into the agenda overview. All right. So today, like I mentioned earlier, is our second and last dental provider work group session. I'm Augustine Leone. I'm with Government Performance Solutions, and today I'm here to just help guide us through today's session alongside the HICPUF team. We have 2 hours, and the agenda is structured to both inform and while also inviting your input. So we will start off by just grounding ourselves in the purpose of this work group. Then we're going to share a bit about the framework we're using to guide the rate review process and certainly this meeting. And then the heart of today's meeting is really around benchmarking, specifically around assessing other states as potential comparators for Colorado's dental rates. And we'll walk through some methodology, selection criteria, and data sources, and then spend most of the time discussing states that may be appropriate benchmarks for the Medicaid dental program. We will also touch on civic data. We've also created space for open discussion and Q&A along the way. And as always, we will close with next steps. Next slide. All right, so why are we here? Well, the purpose of this work group is fairly straightforward. It's really to bring this group, this community together into the benchmarking process. So in other words, we're here to look closely at comparability of other states' dental programs and rates to Colorado's, and identify where certain benchmarks may or may not align together with you. And this is not a typical rate review discussion, if you will. It's more of a technical dive. And when benchmarks don't quite fit, we certainly want to hear your expertise to help us understand why and to inform, how we approach those comparisons moving forward. And of course, when there are really, really appropriate benchmarks, we absolutely want that input from this group as well. I also must be just clear and explicit about what this meeting is not. So it is not the place to request rate increases. That does happen through just a separate process. It's also not a forum for broader policy change requests, and certainly not a venue to discuss current budget challenges. These are important conversations, but they do happen elsewhere. So today we really want to keep our focus squarely on benchmarking and how we select, comparable states, uh, useful data sets, and how we interpret comparability. If you do have feedback for ideas or topics outside of today's scope, we have the rate reviews team email here at the bottom of this slide. So all of that input that is sent there will be communicated back with MPRAC members and certainly just becomes part of the broader feedback record. Next slide. And the
Sorry about
framework.
that.
Not a problem. One more slide, please. Little lag. So, as you may recall, this is a 2 meeting series focused on benchmarking. Last month, we kicked things off. I want to say it was September 10th. And really, we just wanted to lay the groundwork. That was very much just a foundational meeting. We introduced the purpose of this work group, the process we're going to follow, and began collecting some of your feedback and information that you had for this team. Today is our last meeting, and we're going to spend our time reviewing the input that you've shared since September. And we're going to walk through a few different key decision areas, including DIDD benchmarking, the use of civic data, and of course, the potential benchmark states. At the end of the day, our goal is to really just align on a path forward, not only in terms of which states make sense to compare against, but also how we handle any analytical gaps or limitations. Next slide, please. And much like last time, we are again in a Zoom webinar, but we have made a few changes just to improve the flow. First and foremost, and probably what I would call the most important point of performance today is we will not be using the Q&A feature, so that will not be monitored today. It was at times just a bit difficult to reconcile and understand where we were at in the queue with the Q&A feature. So if you would like to speak up or weigh in with input or feedback, we're going to ask that you just raise your hand. And use the raise hand feature, and we'll just call on folks in the order that hands go up. So I'll do my best to monitor that. So this will just help ensure that everyone's had the chance to be heard without using the Q&A feature. So yes on raising hands, no on Q&A, and then of course we will be using today, new to this group, the Zoom poll function at a few key points in the meeting. Specifically, anytime that we are asking for the group to gauge the group's consensus on benchmark states, the use of civic data, DIDD benchmarking. And then on the materials front, there are still two read-only Google folders, the dental HICPUF folder. This has everything the department has shared, slides, agenda, and recordings. And then the dental providers folder, which is where all of the information from you all, everything that's been collected and shared as a part of this process lives. So following today's meeting, everything will be recorded in the dental HICPUF folder. Next slide. All right, let's chat a minute about the approval process for the benchmarking methodology. There are three approval authorities in this process. First is just this work group. Then we have, of course, HICPUF department staff who will review the recommended list coming out of today's meeting from this group to just ensure alignment with program goals and just technical feasibility. And then we have Optimus, HICPUF's actuarial partner. They're going to provide just insights based on their experience with Medicaid rate setting. So once all three groups have reviewed and approved selections, HICPUF will then send a confirmation email out to this group so you know what will be used in their analysis. So if any changes are made to this group's approved recommendations, that will be clearly explained during the upcoming, or not the next MPRAC meeting, but the March MPRAC public meeting, so that the broader community understands, what was finalized and why. Next slide. So the criteria that we're using to evaluate and select appropriate benchmark states for this analysis, let's start with fee-for-service first and foremost. We're focusing on states with fee-for-service Medicaid models since this benchmarking process is designed to evaluate Colorado's fee-for-service dental rates. We're also looking closely at alignment with Colorado Medicaid policy. So this might look like scope of dental benefits or the program size and structure. And of course, we're just looking for states that resemble Colorado and how they cover and pay for dental services today. And then geographic proximity and demographic similarities. These are also very helpful, but not necessarily required. Sometimes the best comparison can come from a state that isn't quite in the Mountain West region. And then out of today, we are looking to land on that provider supported list for comparator states. And you will see at the bottom of this slide just a note on cost of living. HICPUF does apply a standardized cost of living adjustment to all external rates. So let's just try to not bring that into our decision-making criteria, and certainly not the discussion, given that it will be handled by the HICPUF team. Next slide, please. We also do want to acknowledge a question that has come up, and that question is as follows. Well, what about commercial rates? So while commercial dental reimbursement schedules might seem like a logical reference point, there are several important reasons why they just don't work well for Medicaid benchmarking. First is commercial rates they're just highly variable. They're shaped by market dynamics, negotiated contracts, and cost sharing arrangements, and that variability really makes them difficult to compare and even harder to just generalize to Colorado's Medicaid population. Commercial rates, populations and the benefit structures, they're also just very different. Commercial dental plans, they tend to target working age adults with employer-sponsored insurance, and that's just a different demographic than Medicaid. Commercial rates also just tend to be higher than Medicaid reimbursement. So using them as a benchmark could create inflated expectations and ones that just don't reflect the financial realities of the Medicaid program. And then finally, most commercial fee schedules are proprietary, which just limits how HICPUF can access them, use them, share them. So for these reasons, uh, we're not really going to advance commercial rates as a benchmark, but we did want to name the issue and just be transparent about the rationale. Next slide, please. We're getting close to the fun stuff. Only a couple more slides. So let's talk about how we will manage these decisions and discussions together as a team and what the voting process is going to look like. So we are going to walk through just a focused set of topics, starting with DIDD benchmarking. Then we're going to look at potential benchmark states, and then finally reviewing the use of civic data. So you see that for each topic, the team has pulled together a summary of comparability, and then after each topic, we'll open the floor briefly. So if you have something to add, maybe you've worked in that state or have firsthand experience, we're going to ask that you raise your hand so we can hear from you. I will prompt the group when that time comes. And then at the end of each section, we're going to launch just a quick Zoom poll for you to vote yes or no. And we're trying to make the polling feature and streamline the polling feature to just make it as simple as possible. So signal to us whether or not you believe that option is a good comparator or possibly a good data source for Colorado with a yes or no vote. So we are using, again, polls to gauge consensus. And then if you do have additional states beyond what we are bringing to the table here today, or ideas that just aren't captured yet, we'll also have an opportunity to bring those forward as a part of today's session. So before we dive into our first voting topic area, uh, what questions can myself or the HICPUF team answer just about the process we're going to follow today? Lauren Harvey?
Hi, thank you. This is Lauren Harvey, Director of Government Relations for the Colorado Dental Association. I do have a question on the voting that you all would like to do today regarding the other states benchmarking. We sent feedback about kind of that as a general idea, but I looked online at the shared folder and I didn't believe that I saw those states' Medicaid fees posted in the shared folder. Did I miss that? I would want to be sure that anyone involved has enough time to actually review the Medicaid fee schedules and data around other states before maybe having to make decision around which states to use, but I don't know if I missed it, but was that information shared about what those states' fee schedules are?
We did not receive any feedback on the benchmark states from the providers, so we used the feedback from our previous review as well as Optimus suggestions. So we will have the initial analysis listed in the slides following up.
Yeah, we have a summary of the initial analysis when it comes time to vote. And then I saw a hand by Jeff L as well. Jeff?
Yeah, I guess I had a question similar to Lauren's, and it doesn't feel like we're gonna have a lot of time to look through all those different codes and things if we're gonna go through all those states today, but it'd be nice if we could have some time to study and look at those codes and give you a little bit better feedback to me. But that was my kind of question as well. Thank you.
Yeah, I understand your concern. I think that's the question we asked, the action items we asked the providers to take back from the last meeting, and to allow you guys, allow provider to study the benchmark states first, and we will discuss, your feedback. And since we did not receive any feedbacks, that's why we provide our input.
Kevin Patterson. Kevin, go ahead. Did we put that? May have put your hand down. Not a problem.
Oops,
Jeff,
sorry.
is that a lingering hand? Oh, Kevin, are you going? Go ahead.
Yeah, can you hear me now? Sorry, I was on
Yes,
mute.
we can, of course.
So I'm past president of Colorado Dental Association, oral surgeon, Colorado. Similar concerns to Lauren and Jeff. I did not assume that we were supposed to have done all the legwork on our own part to look at the other states' Medicaid data. I had assumed, and I think we all assumed, that that would have been provided for us. So again, same concern in that how are we going to adequately have an opportunity to vote on these numbers when we're going to be looking at them for 10 seconds on the screen?
There is, and we certainly acknowledge that there are some limitations with the process. To Way's point, for folks that joined about a month ago, we did ask for input just on other potential benchmark states. So we'll present 8. There will be a summary of what that looks like, and then we can also invite, and at that time we'll also invite input so that we can have as much information on any given state before you all just signal if you think it is a good comparator for Colorado's Medicaid dental program. Ling Ling.
Yeah, I hear your concern from the provider community. We still continue to present the information we have for the benchmark state today, and we are open. You give us like a follow-up feedback. You can do your afterwards research, and we will consider your feedback. As we mentioned before, this is only like one link, and we will continue to engage with you and the policy people and Optimus. Thank you.
All right, Lauren, and we do see your comment in the chat as well. We acknowledge it's an imperfect process. We are just looking to gauge support. And when we're saying gauge support, that doesn't necessarily mean it's a final decision. We just want to understand where the support lies across this group. I want to say I saw Kevin's hand before Carolyn, so let's go Kevin and then Carolyn.
Great, thanks. Again, I just want to reiterate the importance of what we're trying to do is figure out a way for HCPUF and Medicaid to get dental providers. If we're not using reasonable data to provide reasonable reimbursement strategies for dentists in Colorado, I can guarantee you 100% that we will not be able to get any additional providers, and we're going to lose a significant number of the providers that we are actually able to convince to join and provide care for Medicaid patients. So I realize this sounds like it's a bunch of technical issues, but what you have at stake is whether or not you're going to have providers to deliver the care that you're determining the reimbursement rates for. And if it's not adequate for dentists to be able to provide care, meet their overhead expenses, what you guys need to understand is that every dental office is a mini surgical center. So we provide care, we provide the office space, the cost of the materials, and anything that we do for the patients is included in what's reimbursed to us. So I just need to stress the importance that if it's not adequate, you're going to lose providers. Thank you.
Kevin, thanks for sharing your concern. Ling Ling, and then we'll go Carol.
Who is first?
May have been Carolyn. Carolyn, you go ahead.
Hi, can you hear me?
We can.
Okay, great. I would echo Kevin, Lauren, and Jeff. And I believe last time I was on this call, there were only 8 of us from the community. So we're at about half of the people on the call having an objection to how it's going down. And so I would just raise that concern.
Thanks for your feedback. In the 2019 dental review, we used the benchmark standards. In 2023, we used the ADA data. And after in the second half of the 2023, we made agreement with the Colorado Dental Association. We say for the next dental review, we will use a dual benchmark system. One, it's from other states. Second, it's from ADA or other alternative source. The reason we need to use other states, it's a consistency and equity to other service. For all fee-for-service category, we first seek Medicare as the benchmark. If Medicare is not available, we usually seek from other states. And I totally understand your concern about the provider network. That's the direction we work together. Thank you.
Okay, folks, I'm gonna propose that that we do press forward, acknowledging there are some concerns and limitations. No process is perfect, and again, we're just looking to gauge support or strong dissent for any of these 3 topic areas, and then the 8 states in the benchmark state discussion. One more, please. Okay, so in terms of our first voting topic, it has to do with DIDD benchmarking. So in terms of provider input that was received on this topic, there's a recognition that caring for individuals with intellectual and developmental disabilities often requires more preparation, time, and specialized training. Providers have also expressed that using other states' fee schedules to benchmark these services may not be appropriate, and there has been strong support for tying DIDD dental rates directly to Colorado's Medicaid dental fee schedule. That input does also align with recommendations made by the MPRAC during the 2025 DIDD review. There they recommended increasing any rates below 100% of the standard Medicaid dental rates to 150% and adjusting the 3 most frequently used codes that we have here on the screen. to 150% of the standard Medicaid dental rates as well. So, before we begin heading towards a vote and a discussion, here we would be asking whether you support advancing a DIDD benchmarking approach that's tied to Colorado's Medicaid dental fee schedule. So that'll be the question that you are voting on.
Okay.
Before that, though, we do want to pause here and invite the discussion. So, perspective to share support for this approach, raise concerns, or context based on your experience. Go ahead and raise your hand, and we'll call on you in the order that hands were raised. Jeff.
Yeah, I mean, I think if we were looking at our current Medicaid reimbursement rates for that, I think the 150% would probably be a pretty reasonable place to start for most of those. Depending on what the next review process is. You're kind of asking us to do on one that we don't even know what the Medicaid rate's going to be going forward, but I know we're behind for the DIDD rate. So for this year, for that, I feel like that's probably a reasonable place to start. Yeah.
Thanks for your input, Jeff. Other comments?
Okay, since
We have from Kevin Patterson before we open the poll.
Thanks again. Again, I'll reiterate what Dr. Lodel said. I agree. I think in this population, which are notoriously more difficult patients to provide care for, that the 150% rate increase over current Medicaid rates would be acceptable for dental providers.
Excellent. Kevin, Jeff, thanks for that. I'm going to just give one last call for comments. All right, Wei, I think you're clear to open the poll here. Again, we're asking whether you support advancing a DIDD benchmarking approach tied to the Colorado Medicaid dental fees schedule. Signal support by voting yes, dissent by voting no.
Yes, I just want to remind, thanks for your input, but this is not voting for the rate to be 150%. This is the voting to use the state plan as the benchmarking process.
Yeah, Wei, thanks for that clarification. Voting on the state plan as the benchmarking process. Let's give folks just another second if that nuance changes their vote before we close the poll.
Okay. I just give a couple more seconds before I end the poll.
I think so. I think we're in a good spot to close it.
Yeah. Okay. I need to poll.
All right. Well, folks, we have our first rep, and we'll become more swift and efficient with this process, especially as we get into the states, which is our second major voting topic. So I'm going to ask the HICPUF team to advance the slides. All right, so second voting topic, benchmark states. Again, one thing to note is the HICPUF team did not receive any provider input on other benchmark states during the comment period. And as the HICPUF team mentioned a little earlier, the list presented here today comes from two sources, the 2018 MPRAC review or recommendations from Optimus. That's a HICPUF's actuarial contractor. So the states listed below offer coverage across procedure codes, with 78% of all codes represented in at least 2 states. And then the 8 states currently proposed for consideration are New Mexico, Illinois, Montana, Nebraska, Oklahoma, Oregon, Tennessee, and Wyoming. So we're going to go through each of these states individually in the following slides. We'll present just a summary of the analysis. I will then open it up for comment and discussion. There you can share your support, your concerns for using that state as a comparator, and then we'll open up the vote. It'll be, again, just a binary yes, no. And it's Wei.
Yes. So we just had a discussion because the providers didn't get a chance to review the states, and they probably feel not certain to vote yes or no at this moment. So we will present the slides, and we will not do the voting this time for the benchmark states. So we'll provide information here, and we will, in the follow-up email, we will send out the list of the states. So you can study, and then we will receive your feedback following this meeting.
Yeah, I think that's a great approach. I like it. All right, so let's talk a little bit about New Mexico. So this state was used in the 2020 or 2018 MPRAC dental review. As many of you know, I did win the geography bee in 4th grade, but geographically it is close to Colorado. So that may support some similarities in provider environments. Let's not read too much into that. And then importantly, New Mexico maintains effective fee-for-service rates for about 51% of the CPT codes in the dental review set. Anything else to share, HICPUF team, on New Mexico before we move to the next state? And I would also offer the meeting participants, folks, who have additional context or experience with New Mexico, definitely, weigh in, especially while we have you here. It would be really, really great to at least have some collective wisdom rather than me just buzzing through the slides. Lauren Harvey.
Hi, thank you. Again, Lauren Harvey from the Colorado Dental Association. This is a general overarching comment for each of the states, but I just wanted to ask a question and provide a comment. I would want to know if HICPUF has information about how New Mexico sets their rates and what their methodology is. And again, that will be a question for each state. And just a note, which we did put in our feedback that we sent, that our concern again with the benchmarking to each state is when we do not know what their methodology is, then we won't know how they're setting their rates. And again, that can lead to issues such as the echo chamber. I think last time one of the providers pointed out that maybe they're setting their rates to Colorado, and so how would we deal with that? So I did just want to ask that question and provide that feedback that would apply to each of the states. Thank you.
Wait, I see your hand. You may have a response.
Maybe okay. Yeah. So I want to talk a little bit about this state benchmarking echo issue. So first, we benchmarked against the ADA in 2023. And second, when when states benchmarking, they normally use other states as a reference. It's not a replication. So so they will think about their own, the states will make adjustment based on state-specific needs, cost of living and wage, and program structures and provider mix and access challenge, and state budget constraints. So Normally, I would think when a state benchmark against another state, it is not a copying, it's a calibrating. I just want you to keep that in your mind. Okay.
Thanks, Wei. Jeff, and then Leah.
Yeah, I mean, that's helpful for us. And I think it'd be nice if you guys can provide us like those fee schedules. Like I was trying to look for New Mexico's, it points me to DentaQuest, but it says points me to the provider for New Mexico. So some of those seem like they're hard for us to really find those fee schedules for them. So in the stuff you're going to send out to us, it would be nice if you could send us that data for us. Thank you.
Yes, we can send out the fee schedules, and also there is one place, actually one central place you can find dental fee schedule for all the states. It is under ADA website.
All right, let's
They
go.
have a link to other states' dental fee schedules.
Thanks, Wei. Leah, go ahead.
Hi, can
Leah.
you hear me now?
Yep, we can hear you.
Okay. Hey, yeah, thanks. I wondered if it was possible if you can amend these slides before you send them out for us to take a look at, if you would include things like the cost of living in that state versus Colorado, and also the percentage of providers, maybe break it up GP to specialists that participate actively in the Medicaid program in these states, as our end objective is to increase access to care. So it would be good to understand, are the fees of these states supporting an adequate provider network?
Yeah, thanks for the slide amendment suggestion. Kevin P, and then we'll go to Ling Ling.
Thanks. Actually, I reiterate exactly what Leah Schultz mentioned to know, exactly what the participation rates are from the different dental providers in each of these states.
Thanks, Kevin. Ling Ling.
Sorry, we sent the same message. Let me see. First, I want to say, add a little bit to Way's feedback. We still expect you to do your own independent research after this meeting. So welcome. You still can share any inputs. You can recommend a new benchmark state to us. First one. Second one, for those questions like rate methodology or provide the network, we will try to do the research, but we also need your expertise. Yeah, thank you.
All right, anything else on the topic of New Mexico before we give a brief overview of Illinois and then request your input and expertise on Illinois? Off to Illinois. All right, so Illinois was included also in the 2018 MPRAC review for other services. It was also suggested by Optimus just based on their experience across Medicaid programs. Illinois has fee-for-service rates that cover 37% of CPT codes, which looks like it breaks down to 45% of adult CPT codes and 27% children's codes. They offer coverage for children, adults, and pregnant women. So if you have comments, prior experiences, thoughts on Illinois, go ahead and raise your hand. Seeing everything and anything. All right, I think we are clear to move to the next state. Montana. So Montana was a part of the 2018 MPRAC Dental Review. Montana, as many of you know, sits in the Rocky Mountain region, giving us reasonable geographic proximity as a comparison point. In terms of population coverage, Montana includes both children and adults, and then it offers effective fee-for-service rates for about 52% of the CPT codes. Provider comments, wisdom, experience, expertise on Montana. Leah, thanks for raising your hand. Go ahead.
Thanks. I just wondered, I know you're in this role of facilitator, but when you were asking us for feedback on things we are just now presented with, what kind of feedback are you looking for that is state specific? I feel a little inadequate here.
Yeah, I think that's a great question. I think if there's any way to, add context or color beyond what's included on the slide, or thoughts on comparability to Colorado's Medicaid program, its structure, those types of things would be anything that we would be interested in. Ling Ling, I saw your hand.
Thanks for your question. Actually, we have another provider work group for the 2026 review. Is for the PBT, the pediatric behavioral analysis service. And during that meeting, when we present the benchmark state, for some provider, some of them have really good knowledge about specific states. It's same to here. If some of you have good knowledge about that state, please share with us. But if you don't have, you don't need to give us feedback. Thank you.
Yeah, pros and cons for considering the state, prior knowledge and experience with the state or its Medicaid program. Anything to just round out our understanding when considering the state as a comparison to Colorado.
Okay, thank you. I have a follow-up question too. Like, what is the relevance that we used them as part of an analysis 7 years ago?
I'm gonna lean on the HCPF SMEs. The question is, why is it having been a part of the 2018 MPRAC Dental Review relevant? May I see your hand? There you go.
Sorry. So is there a question why the 2018 MPRAC dental review Montana was in is relevant to this? Okay, so since we asked for benchmark state request from the providers group and we did not hear anything, and so we picked the ones that used before and also suggested by the Optimus, our actuarial firm, and to provide some information here, to present some as a starting point and present information here.
Okay, so for clarity, we're essentially using what we used 7 years ago, and then an actuarial firm, and that's how we're getting the
It's
state.
not we are using them. This is the initial list that we provide because we did not hear any input from the providers group. So these are the recommendations from previous years. But when we are going forward to do our research, do more deeper analysis on these states, we may find these states may not be a fit, and or we may find something else. As we mentioned in the previous in the slides, at the beginning, we have to go through 3 authorities for benchmarking process, right? The first process will be from the providers. And since we don't have that, then the next 2 steps will be from the HCPAF staff and also approved by our actuarial firm.
I see. So is it that, like, as a provider, I am adamantly opposed to using other states to benchmark? And so that is like a feedback point from the providers. I'm just curious, kind of hearkening back to the beginning of this meeting, if we have overwhelming input from providers that we feel as though it's unrealistic and really kind of ineffective to benchmark off of other states. Can we use that as part of the feedback, or are we committed to no, part of this must be a state benchmark, a state to state benchmark?
So as Lini mentioned, we've been using dual methodology for dental related services. So we will consider your feedback, and we will, in this case, it depends on our voting results at the end. And so it is possible that we'll be using dual methodology for this.
Okay, thanks.
Because all our other services, we use Medicare first and then benchmark state second if there is no Medicare to benchmark against. So services that we have some equities to we need to be fair, right, to all the services. Yeah.
All right. Next hand was Kevin.
Thank you. I just wanted to follow up on what Leah Schultz was mentioning in that. I believe even at the first meeting of this group, which I'm having a hard time understanding why it's called a dental provider work group, because we're not being allowed to participate very much in the work of this group. But I believe we provided reasons why we didn't feel other states were useful as being used as benchmarks, and actually offered up data that was put together, with over the last several years, very specific to, potential benchmarking for the state. So I think the fact that nobody from the provider group said, hey, use these states, means that we did not feel that it was worth using that information as benchmarks.
So, okay, sorry, I need to raise my hand first.
Let's go to Molly.
Hi, thank you. My name is Molly Pereira. I'm the Executive Director of the Colorado Dental Association. The reason why you didn't, you keep saying we didn't get any feedback, but the reason you didn't get feedback is because none of the providers that we have spoken to or have heard from believe in the state-to-state comparison for establishing rates. That is why you have not heard any feedback on that. We are literally getting email after email at the Colorado Dental Association from providers, and I wanted to read you just part of one that came in last week. This doctor is an endodontist and says, endodontics is a highly specialized part of dentistry. It requires advanced technology and training and cannot be sustainably delivered with lower reimbursement levels. If rates are lowered, I will have no choice but to stop accepting new Medicaid patients altogether and shift my focus back to referring providers. The patients I've treated through Medicaid are among the most kind, respectful, and hardworking individuals I have ever met. They are mothers, fathers, and young adults striving to care for their families. Without access to endodontic treatment, these patients will be left with extractions as their only option. I don't know where these patients will go if providers like myself cannot continue to participate. And I really want to get back to the core of why we have this program. We need to have providers help these patients in a sustainable manner. The rates as they are in other states are not sustainable. And I really think that we should set the benchmark for the nation and use the rates provided through Civic, use the rates that the 25 codes were raised to before, because that really spotlighted Colorado as a state that cares about its patients and how to help them properly.
Molly, thanks for that. And I do just want to remind the group that this isn't the place to lobby, so to speak. We are here to talk about benchmarking. The next person was Lauren, and then go to Wei.
Hi, thanks. This is Lauren. I put some information in the chat, but just quickly, I think the challenge we are trying to share here is that the way, when you say that Medicare is typically used, but can't be for dental for obvious reasons because it doesn't exist, but the way that Medicare determines their fees has to do with the work provided by the clinician to provide the service, the practice expenses, including staffing and infrastructure, and the professional liability insurance costs. We are not able to see how other states are setting their fee schedules in order to account for those factors, which we believe should be accounted for, the cost of providing care. So it's very challenging for us to consider which states to benchmark to when we are also not aware of how those states are accounting for those cost measures in their benchmarking. So it's one thing to say this state is close to Colorado and also has coverage for children and adults. Okay, that's good to know, but it doesn't inform us of how that state is determining what their fee schedule looks like based on the cost to provide care in their communities. And so I just want to reiterate that you did not hear from the Colorado Dental Association about which states to benchmark to because we do not believe that those are appropriate. That's the appropriate way to benchmark. And we've provided our suggestions about what is a better way to benchmark to accommodate the cost of providing care and to try to have more providers be able to enter the program because there will be adequate pay to cover cost of care. All that to say, if you are telling us now that the only benchmarking you will consider is to other states, then we may have to regroup and think if there are other states. But that is the reason we did not provide other states because our understanding was you were asking us what our feedback is about how to benchmark appropriately to look at, what will be appropriate rates in the Medicaid program. So I just wanted to reiterate that that is why you did not receive specific states from us. Thank you.
And noted and received, Molly. Wei, you are next.
Okay, so I want to say a couple of things first, and before I invite Kevin Martin to speak on this topic. I really appreciate input we received from CDA because that's the only input we received. So we heard you, and so civic data is a consideration, and we will present information here later. So that's one thing. And we did not hear back from other providers against benchmark states. That's why benchmarks benchmark states is definitely a topic here. And also we mentioned dual benchmarking methodology is an option to adopt. So we're not saying benchmark state is the only option. So this is a work group, as we mentioned. in our last meeting, and we guided through the options and the action items left for the providers to do their homework, and we send out follow-up emails. So we do appreciate your time and your input on this. Kevin, will you be able to speak about this, please?
So we have heard you that you would like to compare against the commercial data, and we've committed to including that in our review. To be fair to all of the other services that are compared against some kind of public payer, as opposed to private payers, we are also going to include an analysis that is compared to public payer data. So, we're asking for input. If you strongly oppose giving input on which public payer sources, that is totally your prerogative. We can just choose those on our own. But since we are trying to be fair to both the dental community and to all of the other service communities, we are going to be including both comparisons.
Yeah, Kevin, thanks for that. Okay, so hearing certainly not a whole lot of support for state-to-state comparisons. We do have a couple of more state overviews to go through. If that's something that we feel like at this point in time isn't a great use of folks' time, we can move to discussing the use of civic data, or we can continue forward with just the broad overview of each state, and continue on the process that we have followed for these first three states. So this is a decision in terms of how we handle this portion of the agenda that a question that I'm posing to the group. Leah?
Yeah, thanks. I mean, Kevin made it pretty clear that we're pushing ahead with state to state benchmarking. So you all have done the work. I would welcome hearing it. I think this just changes our approach with how we will respond after this meeting. And I now have better clarity on what this group was looking for from us, and kind of the guardrails that we're operating within. So I would say, show us what you have.
Leah, thanks for raising your hand and weighing in. With that, let's move on to the next state. All right, Nebraska, like probably all of the other states listed here in the 2018 MPRAC Dental Review. Many of you are aware, also one of our neighbors. Their program covers both children and adults, and its effective fee-for-service rate coverage is a bit lower than some of the ones that we presented earlier, with 34% of CPT codes represented. You can see a little bit of breakdown there, 47% of adult CPT codes, 20% of children's CPT codes, which looks a little lower. Provider comments, thoughts on Nebraska, prior experience with Nebraska, pros and cons for considering Nebraska, any and all things related to the Nebraska dental program and its suitability to be a comparator to Colorado. Leah?
Yeah, thanks. sorry, I know you guys have done some data analysis already, and you mentioned things like cost of living. And do you have that information right now that we can also take into consideration during this? And the percent of providers who participate actively in the network? Or is that something we can expect afterwards?
Way, looks like you're jumping in, but you're muted.
Sorry. We do not have the provider participation information right now. Normally, we receive the information from Civic. We will do our research to see if we can provide the information afterwards.
Okay, sounds good. Thanks.
Sure. Yeah, but the cost of living information, it is the link I send it into the chat. And I just want to remind everybody that cost of living adjustment is applied when we do benchmarking against other states. So, so just keep that in mind.
Ling Ling?
I believe the civic data only has the provider participation ratio for Colorado, not for other states.
Okay, that's a good point. Okay.
Yeah, the all player claim database is something that is actually pretty robust and unique to Colorado. That is not generally available information because most other states have not put that kind of effort into that infrastructure.
Kevin, thanks for weighing in about the APCD. Leah.
Sorry, so if we, as part of our homework, I'm now like personally invested in understanding what the provider adequacy for like state to state networks are. When you've looked at that in the past, how have you gone about that? Do you like contact the equivalent of HICPUF in other states for that information? Or like, how did you come to get that?
We're just looking at Colorado provider participation over time. We don't have that information for other states.
Oh, so that has not been included in any historic benchmarking, like as an input point?
No.
Now, for all
Ah.
services, we just only find the information from the official website. We hope we can build a network, has deeper engagement with other states.
I see. Okay, thanks.
Pausing to create a little space before we move to the next state. All right, Oklahoma, similar to I think every state we've reviewed so far, 2018 MPRAC dental review, close to Colorado. Oklahoma's program covers adults and children. And then in terms of data availability, they have effective fee-for-service rates of 59% of CPT codes. That's 71% of adult codes, 45% of children's codes. Comments, thoughts, pros, cons for Oklahoma. All right, let's go to Oregon. All right, Oregon is not only on the list because they were included in 2018, it was also a state that was recommended by Optimus. So it sounds like that does come with some analytical backing, so to speak. And then here we have a 46% of CPT codes. So the floor is now open for Oregon. Lauren, go ahead.
Thank you. Are you all able to share the analysis from Optimus about why they would suggest a state like Oregon or any other states? What goes into that analysis?
Okay,
HICPUF.
sorry, yes.
Go ahead.
We typically don't share the methodologies at the beginning of the analysis because they it takes time before they do a deeper analysis. So what they did is they did the initial analysis and check their fee for schedule, fee for service model and rates coverage and policy stuff.
Kevin Patterson.
Thank you. This is a question on all of these state slides. So you keep having this category has effective fee for service rates for a certain percentage of CPT codes. I'm not sure. Do you understand that CPT codes are for medical procedures and not for dental procedures? CDT codes are used for dental. So I'm not sure what you're even comparing to on these states. If you're comparing dental codes to medical codes, if someone could answer or explain that.
Sorry, it is my bad. It is a typo here. Sorry, it is CDT code. Yeah.
Yeah, apologies for that typo there. Leah.
Yeah, thanks. I just wondered too on the topic of CPT, CDT codes. Are we looking at like when it says that, there's fee for service rates for a percentage of these codes, did we take into consideration at all like utilization of those codes? Are they heavily used codes, or is it literally just a percentage of the available CPT codes, even if it's getting coded 10 times in the state over a year?
This is a rate only, and we only code to code check. It has not we did not include utilization yet, because the utilization data for fiscal year 25 just finalized. So it is one code to one code, not considering utilization. So when we say 46% of CDT codes covered, because we have 438 codes to be reviewed for dental this year, so that's 46% of 436 codes, 438 codes.
Okay, so do your systems allow for like if, I mean, we would know what the most utilized codes are in Colorado? Like, is it possible to look at a fee analysis for like which codes are highly utilized in Colorado, and then to see what states have equivalent rates for those codes? And I only ask because, of course, like some codes are not utilized a lot, so it's meaningless if a state has an equivalent for that.
That's correct. So in the March MPRAC meeting, we do show the top 10 utilized codes. That's also the thing I presented at the beginning for DIDD, why the MPRAC, there are two recommendations from the MPRAC. One is for, in general, the codes below, 100% of the state plan, and the other one is for 3 highly used codes. They want to increase to 150%. Even though they are already higher than the state plan. So utilization is considered and it will be presented in the March MPRAC meeting.
Okay, sorry, wait, you said that was available to us somewhere.
So in March MPRAC meeting?
Like the past March MPRAC meeting?
No, the following one. Because so this is for 2026 review. So the March meeting will be March 2026.
Can we have that information now as we're trying to assess state to state benchmarking and what would like make sense for Colorado?
Okay, so I should be able to provide you top 10 utilized codes, but it's gonna take me some time because we do need to make sure all the claims are for Medicaid members. So we need to get that eligibility information first.
Okay, and does it have to be limited to 10? I'm only asking because it could be like, 8 out of 10 of those could be X-ray codes.
So are you asking for all of them utilization?
We have that? That'd be great.
Okay, so we do have some PHI information that we're not allowed to give out certain codes below certain utilization data.
Okay, can you give us all the stuff that can be released?
Sorry, I have to interject. Leah, I shared the report link in the chat for 2023 and 2024. In the 2023 report, they had the data review. I think you can use that. They should have the top 10 code. Now it's like 2 years, so I don't think the top 10 code for utilization has a huge change. So maybe you can use that information first, and when it's ready to share based on the current data. So like you can save a little bit of time. Yeah.
Okay, thanks.
Yeah, and I also want to add one thing is when we do benchmarking criteria, so picking the states with the highest rate for certain codes isn't a good methodologist to practice.
Lauren.
Some codes might have lower utilization, however, their rate may be really high.
Next up, Lauren with the hand.
Thank you. And yeah, just a quick follow-up on Leah's question. I think for the DIDD dental, you all were able to provide us the utilization percentage for each code. I mean, except for maybe those that you said are protected, but that if that is possible, that would be great. It was just like a spreadsheet with the utilization percentage of each DIDD dental code.
We will see what we can do.
Let's move forward to the next state here. All right. Tennessee, we're looking at coverage for both adults and children. Effective fee-for-service rates for 75% of CDT codes, which amounts to, or breaks down to rather, 71% of adult CDT codes and 81% of children's CDT codes. Looks like one of the higher watermarks there. Questions, comments, thoughts, prior experience with Tennessee context? Anything to add from the provider community on Tennessee? And there's a question from Carolyn in the chat. In 2024, following recent increases. Oh, here we go. Looks like Carolyn response in the chat, pre and post analysis to see the impact of the rate increase. Sounds like that analysis is still pending. All right, next slide. All right, our neighbor to the north. Wyoming, like all of the other states presented, was a part of the 2018 MPRAC dental review with coverage for both children and adults, fee-for-service rates of 51% of CDT codes, which breaks down to 57% of adult CDT codes and 45% of children's CDT codes. Wyoming is the last of the 8 states. Let's create a little bit of space for the provider community to weigh in on Wyoming suitability as a comparator, or we can continue on with some of the other content we're hoping to cover today. We are going to advance, I want to say, a couple more slides. There we go. All right, civic data. certainly has come up in prior meetings, but and even earlier in today's meeting. So certainly heard from the provider community that civic data is valuable just due to it reflecting Colorado specific market conditions, and certainly it's a large available data set that includes 1.9 million people by claim type and draws from just 30 different payers. As far as the civic data set in particular, the data is based on commercial claims and not Medicaid. And then there are also just some, and as we had mentioned earlier, just with the challenges around commercial rate comparability, commercial rates are negotiated, non-standardized, and proprietary, just adding to the challenge of comparison. And then just in terms of initial rates analysis, some orthodontic codes would be filtered out that are just not comparable due to different payment methodologies. And then even with those removals, it looks like the SAVIC data set still provides coverage for about 61% of the Medicaid dental codes. Let's talk a little bit more about the use of civic data. We'd love to hear a little bit more if there's anything else to for you all to weigh in on to round out our understanding of the use of civic data, the merits or the challenges. Jeff, thanks for raising your hand. Go ahead.
Yeah, I was having trouble unmuting, sorry. Yeah, so I mean, Civic is what dentists actually submit for their fees. I mean, there's the different commercial carriers' rates of what they would reimburse at those different percentiles. I would say it's a much better benchmark because it actually reflects the cost of doing business and what dentists were actually charging in their office. Now, we don't expect it to be 100% of what the dentists are submitting for their fees, so don't take me wrong there. But as a benchmarking process, it's probably the best database of what reality is actually happening in the marketplace right now and what the cost of doing business for dentists really are. So I think that's the biggest advantages. I know there's trouble with the ortho codes. And I think there was one other thing in there. I was a little surprised that we only had I thought at some point I saw you had 60%
Towards the bottom, Jeff.
of the codes were there, but because I thought they covered almost 61% of Medicaid dental codes, and I thought they covered most all of the Medicaid dental codes. So I don't know if you guys can provide what codes you feel like they don't cover in there. Would be helpful for us, excluding those ortho codes. So that's it.
Yeah, thanks, Jeff. Lauren had the next hand.
Thank you so much. And Jeff covered some of what I wanted to mention. I would just include, a reminder that when dentists are setting their fees, it is different than, physicians or some other provider types. Insofar as it's really all in one, it includes lab fees, it includes infrastructure, it includes staffing, it includes everything. There's no facility fee that's separate, anything like that. So when those fees are being set by the dentist, it really is inclusive of everything they need to do to cover the cost of providing care to patients. And I also just wanted to kind of go back to what I heard one of the HICPUF representatives mention that Colorado is sort of unique and fortunate to have the all payers claim database. And I think we would be remiss if we as a state did not take full advantage of the fact that we do have that when it sounds like perhaps many other states do not have that data at their hands. So I think it would be a really strong point for Colorado to utilize the data that they have on hand. And I just wanted to also note again around the fact that many other provider types are benchmarked to Medicare. And given that that's not available, again, Medicare really looks at the clinician work to provide the service, the practice expenses, including staffing and infrastructure and professional liability insurance costs. And I think we do believe that the dental fees, as reported in the Civic database that we have access to now, really do reflect those, which is probably closest to Medicare. And one other thing that I wanted to mention regarding comparing to other states, again, if we would need to look at a lot of factors, but I think the cost of staffing can be variable even for neighboring states or states with similar cost of living. But if there are staffing shortages in a particular state for one reason or another, that can really be a different cost factor than even a neighboring state with similar demographics or similar considerations. So just wanted to make those few notes. Thank you.
Yeah, Lauren, thanks for that. Kevin Patterson.
Thanks. I just wanted to speak to the relevance of the civic data. So previously you had mentioned that you had used prior ADA fee surveys, which, as of now, as of 2023, are no longer being produced. So Colorado took it into their own hands to provide data to organizations that can use this type of data to, productively set dental reimbursement fees. So again, I think we need to look at the uniqueness of Colorado in trying to do as much as they can and being at the forefront of trying to make sure that patients are able to get the care they need and providers are able to be reimbursed at an appropriate level. And I think we should look at that as something to use, like Lauren mentioned. It's a very unique thing, and how nice that it happens in Colorado. I'm glad I live here.
I'm glad that I live here too. And any other thoughts on the use of civic data? I'm hearing really continual strong support. So we can certainly open up a poll. I imagine there would be unanimous support, but we can certainly do that just to see where the numbers fall. Thanks for
Right.
voting, folks.
I think we got all the votes. We do have 8 attendees.
We only had 7 respondents in the last one as well. It's possible somebody is recusing themselves.
Okay, so I will end the poll now.
Thanks, Wei.
Sure.
Let's go to the next slide. And I'm not sure we need to display the full poll results. We had support for tying the DIDD approach to the state Medicaid plan, and then unanimous support for using the civic data sets. Next slide. So at this stage, what other questions remain? It sounds like we're at a place where, following today's session, the team's going to work on amending some slides to the best of their ability, with some of these additional elements requested by the provider community, including participation rates, cost of living. We'll also see about utilization and how realistic that is, and then share that back with the group. HICPUF team, what else would you add just by way of next steps before we open it up for final questions and then motion towards adjourning?
We will send out a follow-up email. So I do urge you, all the providers, to read the email and provide your input. So, because we do love to hear back from you, and we take your input into consideration. So, but make sure you do provide your input, please.
Last call for questions. Oh, and I see Jeff. Thanks for suggesting Delaware as a robust program to include for consideration. All right, let's move on to the next slide. So if questions come up after today's session, please don't hesitate to reach out. On the slide, we have the HICPUFS team contact information, and we thank everyone again for joining us today. Keep your eyes peeled for that email coming from the HICPUF team. Carolyn, thanks for suggesting Massachusetts. We'll make sure we add that to the notes. Lauren, Carolyn, Leah, Jeff, thanks everyone for being here and for weighing in.
Mhm.